Traversing through shades of grey, the ordeal to salvage an infected eye. The authors of this video presentation have no financial interest to disclose. A 48-year-old male presented with a history of pain, redness, and white discoloration of his left eye after trivial trauma. He was diagnosed as microbial keratitis, presenting with a total corneal ulcer, dense anterior chamber exudates, as well as vitritis. The corneal scraping microbiology resulted in showing a fusarium species in culture. The patient was started on antifungal and also covered for antibacterial medications. A therapeutic penetrating keratoplasty was subsequently planned because of a very advanced stage of keratitis with endophthalmitis. The cornea was removed in toto with removal of the anterior chamber exudates that were plastered to the iris. A full thickness 12 mm graft was then sutured using 24 10-0 nylon sutures to the recipient bed. The histopathology of the corneal button showed posterior stromal fibers with tiny cocci clumps within stromal keratocytes and in the clefts. It also showed dense neutrophils and few lymphocytes. Cellular debris was seen crossing the descemet membrane. The graft was edematous with a peripheral vascularization, a hypopyon, and a dense fibrinous reaction in the anterior chamber. Gradual shallowing of the anterior chamber with a retrocorneal membrane formation. The vitreous showed dense exudates, and the patient was given 6 intravitreal antibiotic injections to salvage the eye. There was a gradual organization of these vitreous exudates with a shallow choroidal detachment subsequently. The patient was then planned for a repeat penetrating keratoplasty with cataract extraction with a pars plana vitrectomy. After making 3 ports for vitrectomy, an 8 mm trephine was used to mark the area in the corneal graft to be excised. A full thickness recipient trephination was performed. The anterior chamber was then entered. The incision was extended in a circular fashion 360 degrees. The removal of the graft revealed a thick white membrane that completely obscured the view of the anterior chamber. The retrocorneal membrane was incised centrally and dissected. The iris was separated from the membrane during dissection. The membrane was completely removed and the edges were trimmed. The cataractous lens was then removed. And cortex wash was subsequently done. The donor corneal graft was placed. The graft was sutured to the host using 10-0 nylon sutures. A total of 16 sutures were secured to completely attach the graft. Histopathology of the second corneal button revealed stromal edema with keratocyte proliferation with plenty of cyst macrophages. There was a split descemet membrane with loss of endothelial cells. There was no evidence of infection. The histopathology of the retrocorneal membrane revealed a fibroblastic proliferation and plenty of lymphocytes. There were uveal pigments and blood vessels, and a part of the descemet membrane was attached to this retrocorneal membrane. Microbiology of the vitreous aspirate revealed no aerobic bacterial growth and was negative for a panfungal genome and eubacterial genome. Hence, post-operatively, the patients were start accepted on topical steroids and systemic steroids. There was mild graft edema with a well secured and centered graft. The anterior chamber was quiet and deep. The patient was aphakic. He is planned for further visual rehabilitation after the inflammation subsides. The posterior segment showed vitreous echoes with hyperreflective debris which were gradually resolving with retina on. Hence, traversing through different shades of grey, a multimodal approach is required in such cases, especially if it is a fungal infection which have a high rate of residual infection or recurrence. A meticulous surgical planning is required, and patient compliance and understanding of the situation is equally important. Thank you.